fracture छोटा था. I got fracture in my little fingers. Getting better now.
आरटी हो गया या घर पे गिर गए क्या हो?
नहीं ऐसे स्लिप कर गया मार.
Sir, you are live. You can start now.
Welcome everybody to our 46th webinar, Young India Intensivist, and thank you all for joining it from the audience. So today's topic is acute respiratory distress syndrome, the physiology behind management strategies. So the focus in this here will be to understand ARDS. Now what happens in ARDS and subsequently the treatment strategies that we apply, because the treatment strategies is dependent on the pathophysiology. So just setting the ventilator like keep flat so much or keep the driving pressure so much may be all right, but we have to have a deeper understanding to get the optimum outcome out of ARDS, and it has to be explained because especially for a younger intensivist, it is a complex process. It is not so easy. I remember in my younger time it was difficult to understand. And literature is so varied and things develop so much that the idea is to give you the best output. And here we have a very eminent speaker with us, Dr. INDERPAUL SEHGAL, who is associate professor at PHYSIOLOGY Chandigarh, Department of Pulmonary and Critical Care. And sir heads the ICU there, and he's the best person I think to deliver this talk, dealing with this directly. Sir has 200 publications. His research area is ARDS amongst other things, and he has been awarded an ICMR Research Award. So thank you, sir, for taking the effort and the time to make this presentation. Then amongst our distinguished panel, we have Sir Dr. MISHRA from Agra. He is at Pushpanjali Hospital, and Pushpanjali is the largest hospital in Agra. Sir is the head and director of intensive care units, pulmonology and sleep medicine at Pushpanjali Hospital. He is an intensivist and a pulmonologist, very well qualified, and especially having great qualification and interest in interventional bronchoscopy also. Thank you, sir, for spending your time and joining us. Then we have Ma'am Jyoti Goel, ma'am. She is actually the head of internal medicine department again at Pushpanjali Hospital in Agra, which is a prominent hospital in Agra, and she is also an intensivist. She is not only involved with internal medicine, she is a qualified intensivist as well. Thank you, ma'am, for sparing your time. And then we have from Patna, Dr. Arshad Ijazi, sir. Sir is associate professor at IGMS Patna and very interested in academics. He was very eager to join the webinar and share the academic inputs and outputs of this. Thank you, sir, for sparing your time and Dr. Arshad. So with that, I think with the permission of the panel, I will request Dr. INDERPAUL SEHGAL, sir, to start the session, and we will try to make it interactive. In between, have some discussions and some comments, questions, and all. Sir, over to you.
At the outset, I would like to thank Dr. TAPESH for having me speaking on this topic and for your kind introduction. So in the next few minutes or maybe an hour or so, I will be discussing a little bit about acute respiratory distress syndrome and what exactly is the physiology behind what all we do in ventilating these patients. So when I was a resident, when I started my training in internal medicine, and subsequently when I went into my fellowship PM course at PGI, I always had certain questions. How do I start ventilating a patient? What is ARDS? So I had a lot of questions when I was still a trainee. So I have tried my best to keep the presentation as simple as possible, and I would request the panelists to intervene and give their suggestions if I have missed out on anything. So I would start with the case vignette because and this is the format that I am going to have in this interaction. So I will move as the case that a case has come to me and how we proceed and what all things we do for management of ARDS, especially the mechanical ventilation part. And then I'll try to explain what is the rationale behind what we really do. So, a 35-year-old male presented with 5-day history of fever, cough, and progressive dyspnea, which progressed from MMRC 1 to 4 in 5 days. On examination, he had bilateral crackles and he had a bronchial breath sound in the right memory region. Rest of the systemic examination was normal. He had a respiratory rate of 45 breaths per minute and a mean arterial pressure of 60 millimeters of mercury. And on ambient air, his pulse oximetric saturation was 85%, and on a non-decreaser mask, he had a saturation of 94%. So we did an X-ray and it showed bilateral infiltrates predominantly in the lower zone along the perihilar area and distributed throughout the lung field. And the arterial blood gas analysis revealed a PF ratio of 140. So we took a call and intubated this patient and began the mechanical ventilation. So what is ARDS? ARDS is a syndrome. So it is a syndrome which represents manifestation to a wide variety of causes that can cause lung injury. And it is characterized by acute onset hypoxic respiratory failure, generally with bilateral opacities on chest imaging in response to injury to lung parenchyma or pulmonary vasculature. And mind you, it is not a homogeneous disease, it is a heterogeneous disorder. So before I proceed further, we should know what exactly is ARDS and how we need to define, because I've seen many residents using ARDS loosely and calling it ARDS, calling even a patient of acute pulmonary embolism as ARDS. For them, any hypoxic respiratory failure becomes ARDS. But this is not so. So in the definition, we have 4 components. We have the timing, we have the chest imaging findings, and we need to characterize the origin of edema, and then finally we need to characterize the severity of disease that we are dealing with. So as far as timing is concerned, ARDS is to be used only if there is respiratory failure which is acute in onset. So the onset should be within 1 week. And on chest imaging, most commonly chest X-ray, there should be bilateral opacities which are not fully explained by pleural effusion, lobar or lung collapse, or nodules. So if you have findings on chest imaging which include collapse or nodules, so if you can explain those findings with this, then you should not define it as the ARDS, you should not call it as the ARDS. The origin of respiratory failure should primarily be involving the lung and not of cardiac origin. So why this definition has been updated? So before this definition, there was another definition which did not take into account the cardiac failure component. So they said that cardiac failure has to be ruled out. But here if you see, they have included that the respiratory failure should not be fully explained by cardiac failure. So some component of cardiac failure can be included in the definition, and you need to objectively rule out predominant cardiac failure in this. And based on severity of illness, you need to characterize mild, moderate, and severe. Importantly, what the consensus statement has done is they have added deep in the definition. So if you really ask me, this definition is valid only for patients who have been intubated, are on mechanical ventilator, and have a PEEP requirement of at least 5. So this is the fallacy of using this definition, because many patients will not go on to need invasive mechanical ventilation, yet they will have ARDS. So, but for all clinical trials, this is the definition that has been used. More so, if you ask, in the current era of COVID pandemic, many of our patients would be ARDS patients, but if we do not use the value of P, then technically they are not truly ARDS. So based on severity of hypoxemia, which is defined as PF ratio, if it is between 200 to 300, it is mild, 100 to 200 is moderate, and less than 100 is severe. So what really causes, like I said, it is a syndrome. It represents manifestation which can be due to many causes. So this is the normal alveolus as you see. There is the type 1 pneumocyte, this is the type 2 pneumocyte, and you have the interstitium and you have the vascular, endothelium vascular. So if there is injury to the alveolar epithelium cell, or if there is injury to the vascular endothelium, you will see what is called as ARDS. So there will be leaking of capillaries, there will be inactivation of surfactant, the alveoli will be filled with protein-rich edema, there will be formation of hyaline membrane, there will be widening of the interstitium, and all this will manifest as poor oxygenation. So in crux, injury to alveolo-capillary membrane causes damage to type 2 alveolar cells, which are responsible for production of surfactant. Due to decreased surfactant production, you will have atelectasis, you will have reduced lung compliance, which will go on to cause impaired lung exchange. On the other hand, the same injury can also cause inflammatory mediatory response. It can cause bronchoconstriction, vascular narrowing, causing pulmonary hypertension. There will be capillary leak, leading to pulmonary edema and hyaline membrane formation. So all these things are seen in all the garden variety of ARDS that we see. So this is the basic pathogenesis of ARDS. So ARDS has its own time course. Initially, there is the exudative phase wherein you have a lot of pulmonary edema, a lot of alveolar edema. Then there is hyaline membrane formation. Then there is a phase of proliferation wherein there is settlement of the inflammation. Fibroblast will take over. Alveolar epithelial cells will start to regenerate. Most patients would go on to have normal lungs, but some patients will enter a fibrotic phase and will have remnant fibrosis during the resolution of ARDS. So the key pathophysiologic features of ARDS are shunt and ventilation perfusion mismatch. So I want you to imagine a balloon and I want you to imagine a pump. So in lung we have millions of balloons, all of equal size, which are being given air by one pump, which is the trachea and the bronchi. So you have millions of such balloons in the lungs. So what happens in ARDS is that some of these balloons shrink in size. Why they shrink? Because there is loss of surfactant, there is atelectasis of the alveoli, there is filling of the alveoli with the fluid. So that causes shrinkage of the balloons. So you have some balloons which are large, you have some balloons which are small. So if you use the same volume, if you use the same force to inflate the balloons, the smaller balloons might rupture and will not get filled up, while the larger balloons will keep on filling up because they have more capacity. So they have more compliance. So they are more compliant to filling by air. So this is what exactly happens in ARDS. You have reduction in the lung compliance because the number of alveoli come down. And what is shunt? So shunt is that you have an alveolar unit which is completely filled with secretions, but you get perfusion in that area. So you have a physiological dead space there. The ventilation is not there, but the perfusion is there. So whatever perfusion comes does not get oxygenated blood. So it behaves as a shunt in the lung. But not all alveoli will behave as shunt. Like I told you that ARDS is a heterogeneous disease. So you will have some units which are not completely collapsed. They are partially collapsed. They will still have some perfusion. So there will be, and some units will have vasoconstriction, but proper ventilation. So this will add to ventilation perfusion mismatch. There are also secondary alterations in surfactant. there is increased pulmonary vascular resistance, decreased pulmonary compliance, and all this together will cause decreased functional residual capacity. So, like I said, it is really a true shunt. So, it is completely non-ventilated area of the lung. So, you do not have any ventilation, but you have perfusion. It is just like a pulmonary AVM malformation or intracardiac shunt. So, it is a physiological dead space ventilation. You do not have any ventilation there, but perfusion. So, you have true shunt. You have areas with ventilation perfusion mismatch. Some will have low ventilation perfusion, some will have normal ventilation perfusion. That is why you see some response to supplementary oxygen. Truly, in a shunt, you should not have any response to oxygen. So even if you give oxygen in a shunt, you will not see any increase in the oxygenation. And because the ventilation is maintained by a patient, when a patient has acute lung injury, what happens is work of breathing increases, his respiratory rate increases, he takes small breaths but at a higher frequency. In nutshell, he's trying to maintain his ventilation, and that is why you do not see CO2 retention initially, but as the injury progresses, you will see CO2 retention also. And as I told, that type 2 alveolar cells also get injured, so there is defective production of surfactant. Now, surfactant keeps the alveoli open. It has an action of a detergent. So if you see a bubble, if the surfactant is not there, it will just collapse. So this is exactly what happens. There is reduced production of surfactant, and also there is excessive destruction of surfactant. Also because of excessive fluid, whatever remnant surfactant is there is not able to keep the alveoli open. The normal physiological response to hypoxia is pulmonary arterial vasoconstriction, and hypoxia will cause that. This leads on to increased pulmonary pressures and thus contributes to pulmonary hypertension. Another mechanism that causes pulmonary hypertension in acute ARDS is fluid in the interstitium, which compresses the small pulmonary vessels and thus increases the resistance. Importantly, blood flows preferentially to areas with lower resistance, thus contributing to higher ventilation perfusion ratios in some of the regions. And because of these changes, there is effective reduction in the functional alveoli, and hence overall lung compliance and functional residual capacity is reduced. Apart from this, I would also want you to introduce you to a concept of pulmonary and extrapulmonary ARDS. So in our textbook, you can say that the causes of direct and indirect lung injury. So the pulmonary ARDS is any ARDS which results from direct injury to the lung parenchyma. Say for example, community acquired pneumonia. Say for example, drowning. Say for example, blunt chest trauma and lung confusion. For example, aspiration. So these causes lead to direct injury to the pulmonary alveolar epithelium and thus are categorized as pulmonary ARDS. On the other hand, any systemic cause of ARDS like sepsis, like pancreatitis, like multiple transfusions, all these causes will lead on to extrapulmonary ARDS. So in nutshell, the causes which lead to injury of alveolar epithelium may be categorized as pulmonary ARDS, whereas when you have predominant injury to the pulmonary vascular endothelium, you should be able to characterize this as extrapulmonary ARDS. So why should we define these? Because for the same amount of pressure, higher trans-airway pressures are transmitted to the pleura in pulmonary ARDS as compared to extrapulmonary ARDS, which means that you will be able to apply higher PEEP in extrapulmonary ARDS and lower PEEP in pulmonary ARDS because of higher transmission of pressures to the pleura. importantly, the compliance also is poorer in pulmonary ARDS. So like I said, the management of ARDS is primarily supportive. The main issue is that you need to take care of the underlying etiology and try to buy time till it resolves by giving oxygen supplementation, using restrictive fluids, and tackling non-pulmonary organ dysfunction. The most important component of management of ARDS is mechanical ventilation. So based on severity, you have a lot of options for management of ARDS, starting from HFNC, non-invasive ventilation, and also as the severity increases, you can use HFOV, ECMO. So what I'm going to do and talk about today is I'm going to restrict myself to tidal volume, the ventilation strategies, how to set PEEP, what is the role of prone positioning, and what is the physiological rationale behind it, whether we should be using neuromuscular blockade, and finally I would talk about inhaled nitric oxide. Mind you, whether it is mild, moderate, or severe ARDS, low tidal volume ventilation forms the center. So it is the most important strategy that till date has shown to reduce mortality in ARDS. So coming
Dr.
back to
Inderpaul, yeah,
yes,
Inderpaul, before going to the management part, you have described the pathophysiology very well. Just for the just to summarize it and just to make it little simpler for the students, that as we have already discussed that VQ mismatch, you have to differentiate between VQ mismatch and shunting. So these are just two pathophysiology, which is the same pathophysiology and with the increasing severity. So when your ARDS is not very severe, you will have VQ mismatch, and your increasing FiO2 will increase the oxygenation. And when the severity will become more, you will have so much of alveoli becoming collapsed and dense that that no matter how much FiO2 you are going to increase, you are not going to improve the SpO2. That is how you say that it is now the shunting is happening, physiological shunting, which is different from the cardiac shunts, anatomical shunts. So this is the question which is being asked in your exams, that VQ mismatch responds to higher FiO2, and the shunting, when shunting happens, no matter how much FiO2 you are going to increase, you are not going to improve on the SpO2 part. And that is how where the Dr. Inderpaul is going to explain you that where the role of PEEP comes in. Now you have to differentiate. Second thing, you have to differentiate between the primary. You have to remember all the causes of primary ARDS and secondary ARDS, all the causes. There is a very beautiful table in your books. And then you have to remember all the causes. And secondly, you have to remember the closed differentials of the ARDS. Dr. Inderpaul, you have covered the closed differentials also in your, I think.
Ma'am, I don't think he's talking about the etiology. So would you like to elaborate on the primary etiologies and the secondary etiologies of ARDS? And if you can just tell about the etiologies of ARDS a little.
Yeah, the primary, as Dr. Inderpaul has already said, the primary or pulmonary ARDS is like it might be because of pneumonia, sepsis, and trauma, blood. This is like, you can also say it like local or the systemic causes. The local causes are related to lung causes itself, and the systemic causes are related to the to the etiologies like sepsis, trauma, blood transfusion, pancreatitis, post-cardiopulmonary bypass. These are the etiologies which are like systemic causes causing the ARDS, which you can also call it secondary ARDS.
Yeah, I think.
And the primary ARDS, you are very clear that pneumonia, aspiration pneumonia, bacterial pneumonia, viral pneumonia, fungal pneumonia, lung contusion, aspiration pneumonia. These are the causes which are related to lung and can be categorized as primary ARDS.
Yeah, actually the word primary and secondary would probably be wrong from my side. It would be pulmonary and extrapulmonary. And the commonest cause is actually sepsis. Sepsis is the leading cause of ARDS and followed by pneumonia. So these are the two main causes. Extrapulmonary is sepsis and pulmonary is pneumonia. And there's a difference in the outcome of these patients who are having extrapulmonary ARDS and pulmonary ARDS. Now, before we go to that, we would also like to clarify why the word ARDS is being used for some conditions and not for certain conditions. We have certain conditions which come under ARDS and certain conditions which are called ARDS mimickers. So why are we using the word ARDS for certain conditions and not for certain conditions? So anybody from the panel would like to answer that?
Yeah, that is extremely important, because I was discussing about the differential diagnosis of ARDS, because sometimes to pinpoint the diagnosis is so important, because it will help and differentiate in your management strategy. Suppose somebody who is having acute interstitial pneumonia, acute eosinophilic pneumonia, or ARDS because of some fungal infection, or ARDS, or because of maybe because of some malignancy or lymphocytic carcinomatosis. Until unless you will pinpoint the diagnosis, you will not able to. You will do the supportive care as per the ARDS protocol, but along with that, you have to pinpoint the etiology, so you can treat that etiology also simultaneously. So it is equally important to differentiate the close mimickers of the ARDS, so that you can help your patients in your therapeutic management also.
Yes, thank you, ma'am. That is absolutely bang on. So there is a group of conditions which comes under ARDS, divided into pulmonary and extrapulmonary etiologies, and there are ARDS mimickers. So now, why the difference is there between these two groups is actually not very clear, but it is based on the histopathology. Patients who are classified as ARDS actually have a DAD physiology, histopathology on their lung biopsy specimens. DAD standing for diffuse alveolar damage. Though there is some degree of overlap between ARDS etiologies and ARDS mimickers. So that is why certain conditions have been clubbed under ARDS and the others are called ARDS mimickers. And amongst ARDS mimickers, we have acute eosinophilic pneumonia, like she said, acute exacerbation of ILD, whoop, radiation pneumonitis, and so on and so forth. So this is important to differentiate, because though they will have bilateral infiltrates, radiologically you may not be able to differentiate, PF will be less than 300, the treatment will differ. A lot of these conditions respond to steroids or other specific therapies, and BAL has a important role in this. We will talk about BAL and seek Dr. Vipul Mishra's opinion, or maybe you can comment on the role of BAL in diagnosing such conditions, when you should do a BAL or a transbronchial biopsy in ARDS patients. Dr. Vipul Mishra, sir.
Okay, so I'll first make a comment about this pulmonary versus extrapulmonary ARDS. If you see all the recently published literature in the last, ARDSnet trial came in 2000. In the last 4-5 years, there have been a number of publications and a lot of very interesting animal studies which have been done to go beyond what ARDSnet trial suggested, which means low tidal volume. And if you see these trials, all ARDS patients have been treated the same. The differentiation between pulmonary and extrapulmonary ARDS was not done. So primarily, I would like to send this message across, and whether there may be some differences in outcome etiologies, but as far as management strategies are concerned, because the topic of today is physiology behind management strategies. So the physiology and the logic behind and the evidence behind management strategies of patient of ARDS does not differ between pulmonary and extrapulmonary ARDS, and this is very visible from the recent publications who have taken ARDS in one single entity, and in none of these papers which I studied in the last have there been different recommendations and different treatment strategies for treatment of ARDS. That is point number one. The point number two, which Dr. TAPESH has raised about use of BAL in ARDS. I would like to first comment that many patients of ARDS are so sick that bronchoscopy is not possible or very risky. But yes, as the esteemed panel has suggested, that we must try to rule out mimicries of mimics of ARDS. In some cases, bronchoscopy there proves extremely valuable, and one such entity will be ARDS secondly in an immunocompromised patient. Now again, when an immunocompromised patient develops ARDS, the etiologies may be different. It may be, for example, there may be a PJP pneumonia or a nocardiosis or atypical organisms causing, or fungal organisms causing this ARDS. So in those patients in whom a bronchoscopy is possible, and I must tell you, in a clinical practice, not many such patients can have a safe bronchoscopy, but wherever possible, a bronchoscopy or sometimes even a biopsy may be done to catch catch the etiology. For example, we normally treat ARDS with broad spectrum antibiotic, but in those patients in which we are suspecting an immunocompromised patient, PJP pneumonia is quite common, and if you can diagnose PJP pneumonia by sputum, BAL, or biopsy, the treatment can be very simplified and the outcomes can be improved greatly. Thank you.
Sir, in
Can
your
you comment on this?
thank you for your valuable input for BAL, and BAL making a difference, especially in the microbiological diagnosis in atypical cases or immunocompromised cases where the pathogens may be very different. So there the BAL will be important if possible, depending on your sickness of the patient. Secondly, sir, your experience with the outcome of biopsies, if you are doing any transbronchial biopsies, and whether they are really making a difference and if they are getting complications. So if you have any decisions to make on that.
See, I think it depends on what kind of setup you are working it. So, for example, where Dr. Inderpaul is working, doing a bronchoscopic BAL and biopsy, I think he will be able to comment better because he will be dealing with very complicated patients. And of course, in many ARDS patients, if you place the diagnosis right, you may be able to make a difference. And I just pointed out, especially in immunocompromised post-lung transplant patients, biopsy sometimes is necessary in spite of the high risk involved, and it may be very rewarding. But then it depends on what kind of setup you are working in a primary or secondary setup. I don't think many bronchoscopists would like to do biopsies in ARDS patients, which carries high risk of desaturation and high risk of pneumothorax. But of course, in tertiary care setting, like where Dr. Untitled is working, he'll be able to comment better. I would like to draw a comment from his side. In many such cases, even with the risk involved, doing a bronchoscopic BAL and even a lung biopsy, in spite of the risk, may be worthwhile.
Thank you, sir. So we will take his opinion at the end of it about transbronchial biopsies and their role in the management of ARDS. So I think Dr. Inderpaul Singh, sir, please carry on.
Okay. So coming back to the case, so patient was initiated on volume cycled mode of ventilation. His ideal body weight was 70 kilograms. Based on that, we set a tidal volume of 420 ml, respiratory rate of 18 to 20 breaths per minute, peak of 5, FiO2 of 100, and an I/D ratio of 1:2. The saturation on these settings continued to remain 85%. On an ABG, the pH was 7.1, PaO2 of 50, and PaCO2 of 50 millimeters. So what should we do next? Do we increase the tidal volume? Do we perform recruitment maneuvers? Do we increase speed? Do we prone the patient? Or we just paralyze the patient and see what really happens? So any answers to that? Participants are free to say anything.
So I think we have got lost in the original settings, so you please carry on.
So if you ask me, if you chose everything, you would be technically right. But we need to go in a stepwise way, and how we should proceed, let's see. So if you ask me, traditional ventilatory strategies were primarily extrapolated from anesthesia colleagues. They were volume targeted, targeting a tidal volume of 10 to 15 ml per kg body weight. Beef was set as required, and they aimed for normal blood gas values. On the other hand, the current strategies focus on avoiding alveolar injury, facilitating healing of the injury that occurs in ARDS, and the settings are primarily based on the ARDSnet trials. Current ventilatory strategies are pressure targeted with an aim to keep plateau pressure of less than 30 centimeters of water. They involve low tidal volume strategy which is a tidal volume of 4 to 8 ml per kg of predicted body weight, and not the actual body weight. It is the predicted body weight, and generally higher PEEP based on FiO2 requirements. Importantly, the current ventilatory strategies do not target normalization of the ABG, but it should be acceptable within the physiological range. So before we proceed further, this is the pressure time curve, and it shows the inspiratory and the expiratory phase. As the inspiration progresses, you reach the peak inspiratory pressure, which is the highest pressure that you attain during inspiration, followed by a pause and a plateau, which is the airway pressure. Finally, there is an expiratory phase, and you have a positive and expiratory pressure, which is what you set. And the synonym of these terms would, if you use an esophageal balloon and measurements of pleural pressure or esophageal pressure, which reflect the transpleural pressures, you will say it as PTP plat, that is transpulmonary plateau pressure, or transpulmonary positive and expiratory pressure. So just remember these terms. So there are methods to calculate predicted body weights, but you could also use the nomograms, which would be provided with your ventilator. So these are the general methods that you can use. So we select any mode of ventilation. The crux is that we set a tidal volume of 6 to 8 ml per kg idle body weight, predicted body weight, and then we either reduce or increase based on how the patient responds. Initial respiratory rate is set based on the baseline minute ventilation. So if the minute ventilation is about 8 liters, then you calculate it accordingly and set the respiratory rate. And then subsequently you adjust respiratory rate and tidal volume based on your pressure goals and pH. So what are these pressure goals? So after initially intubating your patient and ventilating the patient for about 30 minutes or so, you try to achieve equilibrization of all the pressures. You should measure the plateau pressure and always target this to be less than 30. Why less than 30? Because at pressures higher than this, the airway pressures, higher airway pressures get transmitted to the pleura, increasing the risk of barotrauma. So if after measurement your plateau pressure is more than 30, you either reduce tidal volume in 1 ml per kg body weight steps to a minimum of 4 ml per kg, or you could also reduce your PEEP if you have set a PEEP which is higher. Similarly, if your plateau pressure is less and you still have not been able to achieve your tidal volume target, which is about 6 ml per kg idle body weight, you could go on to increase the tidal volume to keep the PEEP plat less than 30. And the target pH, as I told you, is not normalization, but keeping it within the physiological range, which is about 7.3 to 7.45. If your pH is between 7.15 to 7.3, what we do, we increase the respiratory rate. If we are still not able to achieve our target, what we can do is we can increase the tidal volume if we have used the tidal volume of 6 ml per kg body weight. So it is just doing some mathematical changes or jugglery and trying to achieve this pH, a CO2 of less than 40 and keeping a pH of more than 7.15. However, if you are not able to maintain a pH of more than 7.15 despite everything and you are exceeding your PEEP plat targets, then you may use soda bicarb or you may do other strategies. Mind you, we do not want to achieve a pH of more than 7.45 and if possible decrease the ventilatory rate if you find such a pH. The oxygenation goal is to keep a saturation between 89 to 95% because it maintains a PaO2 of 55 to 80%, and on the oxygen dissociation curve, it falls on that exponential log ratio so that even if your oxygen falls, the patient does not suddenly collapse. That is why we try to keep these targets. a minimum PEEP of 5, and a combination of FiO2 and PEEP can be used to achieve your target. So how we will achieve the optimal PEEP, how we will achieve the optimal FiO2, I will discuss in subsequent slides. So the rationale for low tidal volume is that large number of alveoli units do not participate in ventilation. I told you in the beginning that some of the alveoli would have been collapsed, some of them would be partially collapsed, and some of them would be normal. So you have a small, totally deflated balloon, you have a partially inflated balloon, and you have a fully inflated balloon. So if you apply the same pressure, your fully inflated balloon has the risk of inflating further and causing barotrauma. And that is what exactly happens in ARDS. As you can see, you have only partial lungs which are available for ventilation, and most of your lung is gasless and is collapsed.
Sir, may I just interrupt? So
Yeah.
let me just clarify this concept of baby lung. So the baby lung is not a distinct area of lung which is normal in ARDS. So please be clear about that. It is a functional concept. The baby lung is a functional area of the lung which is normally aerated or almost normally aerated, right? It is not a distinct area as was shown in the CT. The CT is only one cut, but it is diffuse because the disease is diffuse. So the baby lung is a functional lung having well aerated or normally aerated alveoli. So that should be clear. The other thing is PET studies have shown that even areas of the baby lung are inflamed. The baby lung itself is inflamed. It is not normal physiologically. That should also be clear, but it is well aerated and its compliance is normal. So that should be clear to everybody, the concept of baby lung, because many of these students think baby lung is a separate, clear part of the lung, and that is not correct. It is a functional concept that is there of baby lung. And so that is all I wanted to add. Please carry on.
So even if you look at the CT, you see that this is the densely consolidated area. This area has some ground glassing, and this is an area which is normally black. So you will have, so what we call, the pulmonologists call it as head cheese sign. So you will have ground glassing, you will have consolidation, and you will have normal area. So the entire lung is damaged. You will have small components of normal lung parenchyma. Most of it is diseased. Okay, so just remember that you have some balloons which are totally collapsed, some balloons which are partially collapsed, and some balloons which are normally open, and they are at a risk of overinflation as highlighted by this. So in this slide, what I want you to concentrate on is, if you use protective ventilation, which involves giving low tidal volume, you see that the normal alveoli would expand, but it will not expand too much. On the other hand, the collapsed lung will also expand. On the other hand, if you use a high tidal volume strategy, you are at risk of overinflating the normal alveoli and causing more damage. So conceptually, different lung units will have different time constant. So time constant is resistance, product of resistance and compliance. So if you have an area which is low in compliance, it will get filled up early. So most of your ventilation will then go to the area which has a more compliance. Okay, so a smaller lung unit will fill up early and will not fill more. So because that area is small, so the ventilation will preferentially go to an area which has more compliance, and that is the risk of associated with conventional ventilation, where it can over distend the areas with normal time constant. Or I hope I am able to clearly tell you. If you are confused, just let me know. Okay. So not only is there a physiological rationale behind using low tidal volume strategy, we also have dearth of evidence which tells us that using a low tidal volume strategy is actually beneficial. And this is the landmark trial, the ARDS ARMA trial, which actually compared the 6 ml low tidal volume strategy with high tidal volume strategy, and what they showed was that using the low tidal volume strategy not only improved survival, but it also reduced the hospital stay. So overall, using a low tidal volume strategy is going to do benefit to your patient rather than harm. And it is the only strategy till time which has shown an absolute risk reduction of 10% in reducing the mortality. So coming back to the case, we did everything. We increased the tidal volume, we increased the respiratory rate. However, we were able to achieve the pH, as you see, and CO2 was normalized, but still we are not able to achieve our SpO2 target. So what next? So here comes the concept of recruitment maneuver. So should we be recruiting all the lungs? So basically, recruitment maneuver is a transient increase in the transpulmonary pressure. That is, you give a high pressure to the lungs so that you open up the collapsed alveoli. So you blow the air forcefully and try to keep it at that pressure so that the collapsed alveoli open up, and you try to keep those alveoli open. So this is called as the open lung strategy. And there are many methods of doing recruitment. Few of the common ones are using a sustained high pressure for 30 to 40 seconds, and the other ones are gradually increasing P, trying to achieve the lowest driving pressure or lowest plateau pressure with increasing P.
So I would just like to add. So just one thing about recruitment. Just like to clarify that for the audience. Like sir has said, there are many methods. So methods I think we will not discuss, but the concept is that when you do a recruitment maneuver, you give a positive pressure much more than what you are normally giving for a minute or so. So when you give this positive pressure, which is much higher than your inflation pressures while you are ventilating the patient, you open up a lot of alveoli which would not open up with your normal inflation pressures. So once these alveoli are opened up, then you keep them open with your applied PEEP. So unless you give this high pressures in your recruitment maneuver, these collapsed alveoli which are requiring more inflatory pressures to open up will not open up. That is the concept of recruitment maneuver. And one thing you should realize, whatever method you use for doing the recruitment maneuver, please make sure the patient is volume loaded before you do the recruitment maneuver, because sometimes there can be hypertension when you do the recruitment maneuver because the intrathoracic pressure rises during your recruitment maneuver. And third, if your lung is recruitable, that means he's having more severe ARDS. If the lung is recruitable, okay, that means he's having more severe ARDS and the prognosis is worse. That might seem like a contradistinction, but that is the way it is. Because the severe ARDS will have more collapsed alveoli, which are more difficult to open up with your usual ventilation. So they'll be more amenable to high recruitment pressures, and thereby they'll be having more severe ARDS, and severe ARDS has worse prognosis as compared to moderate and mild ARDS. Thank you. Sir, please carry on.
Doctor, just a minute. Dr. Tapesh and Dr. Inderpaul, just for the students' benefit, can you explain how many times and when should you do the recruitment maneuver, and how many times you can do it, and should we do it in the initial phase only or in the later phase also when we do the recruitment maneuvers? So little bit more about the recruitment maneuvers, so that students, I have seen that students, whenever the saturation falls, they keep on trying this. So sometimes overdoing the recruitment maneuver is extremely harmful. So I request Dr. Inderpaul, please explain in detail about when it should be done and how many times you can do it.
So generally, we don't do it more than twice in a day. So as a rule in our respiratory unit, intensive care unit, we do not do it more than twice in 24 hours. That is number one. Number two is, if you have shown that lungs are recruitable, and if you see that somebody has done suction, so in ARDS, doing repeated suction is not advisable. If there is somebody has done suctioning, if there is disconnection of the ventilator from the patient. So whatever recruitable lungs were there, they have collapsed. So at each such event, you may choose to do recruitment maneuver, and recruitment is best to be done in the initial phase of ARDS, especially when there is a lot of pulmonary edema, when they are in the proliferative phase. However, if in the later phase, when fibrotic phase, that is in the second or third week of ARDS, it is somewhere where you should avoid doing recruitment maneuvers. But before doing recruitment maneuvers, I would like to draw your attention to looking for some prerequisites. Number one is patient should be hemodynamically stable. You should not have any shock. You should not be hemodynamically compromised. Number two is you should not have any pneumothorax. Number three is endotracheal tube should be properly placed. Ensure that there is no endotracheal tube secretions or oral cavity secretions. If there are, and if you want to do suction, do it now. Ensure that endotracheal tube cuff is working properly so that there is no cuff leak. Because when you inflate the pressures high, then there are chances that the pressure will leak from the cuff side. And the patient has to be completely paralyzed. So these are the requisites that you must do. It is a checklist, in fact, before even thinking of doing a recruitment maneuver. The next thing that I want you to know is, are the lungs really recruitable? So not all lungs are recruitable. So this is the next question that you should be asking yourself. So high recruitable lung means that the injury is more severe. It is involving more lung areas, more alveoli are collapsed, and the ARDS is more severe. As highlighted by this CT scan, where you see it's more diffusely involved lung, and that is why a recruitment maneuver is likely to open up these areas. Mind you, look at this. These were the areas of consolidation, but this is not normal area even now. This still has got a lot of inflammation, as highlighted by a lot of ground glassing in this CT. Okay, but the concept is, the severer the disease, the more recruitable the lung, the more is the damage. But you definitely want to open up these collapsed alveoli. Why? I will show you in the subsequent slides. On the other hand, there would be some ARDS which are not recruitable, especially when the brunt of the damage is involving one of the lung area and most of the other areas are just showing some ground glass calcification. And most of these areas just have inflammation and are not collapsed. So these are the lungs which are not recruitable, and we should not perform recruitable maneuvers in non-recruitable lungs. So the first thing is checking for prerequisites, and the second question you need to ask is, are they really recruitable? So this is a GOAT model of ARDS. So I will just show you why we should do recruitment. Okay, so this is the GOAT lung. This is getting ventilated. Okay, and this is the esophageal balloon. You can see the volume and the pressure curve. The pink one is the reading of the esophageal pressure monitoring, and this is the normal pressure monitoring that we see of the lung. Okay. So look at this. Now this is a small lung which is collapsed and it is ventilating at a low tidal volume, and we are trying to see whether recruitment is going to really help. So how you do recruitment? This is using a specialized mode of ventilation which is there with Hamilton, may not be there with all. But the crux is you perform a recruitment maneuver. It should be the increase of pressure should be gradual and not very fast. You should start from low pressure, go up to high pressure, give a pause so that the entire duration of recruitment maneuver is about 30 to 40 seconds. Don't go beyond that. Going beyond 30 seconds is going to cause more compromise. So the person has set the recruitment. Now you see how the lungs will open up. So the recruitment maneuver is being given. All the collapsed alveoli and the lung. Can you see that? How the lungs have opened up. So this is what a recruitment maneuver does. It opens up all the collapsed areas. So this is the pleural cavity. This is the pleural catheter, which you can see is hanging there. This is the endotracheal tube, and this is how a recruitment maneuver is done. So once you've done a recruitment maneuver, you get a lot of information from that, whether you have recruitable lungs or whether you don't have recruitable lungs. Okay. So one thing is, with this maneuver, you are able to see a lower inflection point and how to define whether lungs are recruitable or not. You can see the difference between the tidal volume at a pressure of 20, whether the tidal volume in the inflation and the deflation curve is approximately 400. So 400 ml or more. If the difference at a pressure of 20 in the tidal volume is more than 400, it means the lungs are recruitable. And if the compliance is 50, so if the compliance is 50 ml per centimeters, it means that the lungs are recruitable. So this tool may not be available to all. So it is not necessary that you use this maneuver always. You can have a clue about whether the lungs are recruitable or not by just looking at the chest X-ray, whether the injury is more severe, whether the PF ratio is very severe despite ventilation. So there it means that the patient might benefit from recruitment. And if there is no benefit of recruitment after one recruitment maneuver, do not do it again. It means that the lungs are not recruitable. So the risk of ventilating a collapsed lung is that if you don't open up the alveoli, the open alveoli, the alveoli which are already open are at risk of volume trauma. Okay, with excessive stress and strain, there are chances of increased dead space ventilation, and there are potentially chances of high pulmonary vascular resistance, as I had explained earlier. And in the collapsed alveoli, you will see shunt physiology, you will see high pulmonary vascular resistance. There will be the areas will be having low inflammation. So these collapsed areas will behave like this. The potential benefit of recruitment is that you increase the number of open alveoli, you reduce the dead space, you reduce the pulmonary vascular resistance, you improve the homogeneity of the injury, and you see how well the lungs are open. However, not all are open similarly. Some are small, some are not open. So there is still some heterogeneity which will be there always. The potential risk of doing a recruitment maneuver are worsening of alveolar distension, and opening of this collapsed alveoli might increase the inflammatory lung that is available. So it is possible that these lungs were collapsed because there was a lot of inflammation. By opening up these collapsed alveoli, you might actually increase the inflammation further. So there is a very delicate balance between the potential harm and potential benefit when you do a recruitment maneuver. And apart from giving a sustained pressure, you can also do a recruitment maneuver by gradually increasing the PEEP. So here you see the PEEP is being gradually increased, keeping the tidal volume static and increasing the PEEP gradually, so that you are able to maintain a good saturation at a lower PEEP. Okay, so this is how you do a stepwise recruitment maneuver. You gradually increase the PEEP, keep it, ventilate the patient on each PEEP for 2 to 3 minutes, let it equilibrate, and then keep on changing the PEEP. And once you achieve a tidal driving pressure of 14 or less, then you can reduce the PEEP. Another way is, as you can see in this, you give the sustained airway pressure as was done in in the goat lung, and you see the higher the damage of the higher the lung which is recruitable, the severe is the injury, and they will open up on giving a sustained pressure. So in nutshell, if you have severe lung injury, severe ARDS, you will have more recruitable lung as compared to ARDS, which is mild to moderate. So that is physiology about behind recruitment. Whether there is any evidence. So in a previous meta-analysis, doing recruitment maneuvers actually showed that they might improve survival and without any added risk of barotrauma. But then this came the ART trial where they compared lung recruitment with PEEP versus not doing any recruitment and doing ventilating the patients with low tidal volume strategy. And what they found was that lung recruitment did not add any benefit and in fact it increased the mortality. So it is contrary to the physiology behind recruitment that it increased the physiology, it increased the mortality. So what was the problem with this trial? So this trial included patients who had moderate ARDS rather than only including severe ARDS. That is number one. Number two, the recruitment maneuver was giving a sustained pressure of 45 centimeters of water for 2 minutes, which is very high. So you do not want to do a recruitment maneuver for 2 minutes. So that is going to cause more harm. Number three, they did not check for whether the lungs were recruitable or not recruitable. So they have not done the prerequisite checks for that. So I would still say that some of the patients would benefit from lung recruitment maneuver, if not all. And we should be very careful in doing lung recruitment maneuvers.
So Dr. Untitled,
Subsequent
can I
to
come
this
in?
study, there is a meta-analysis which actually has shown that
You
there
want
is
to say
no
something,
benefit
Dr.
in
Amrita?
mortality
No, let him
with
finish.
the recruitment maneuvers, and in fact, it had a chance of more harm. Yes, you wanted
Yes,
to say something?
I wanted to come in about recruitment maneuver.
Yes, please go on.
Yes, so I'm glad that Dr. Inderpaul, in the end, did come out, show the study which showed harm, although with criticism, about recruitment maneuvers. So the question is, what should be the take-home message, and what is coming in the guidelines? Um, there was a lot of enthusiasm about keeping the opening up the lung and keeping it open as part of open lung strategy. But in all these trials and meta-analysis that has been done, this open lung strategy has not shown to improve mortality. And then Dr. Inderpaul correctly pointed out, this is a study which led clinicians to rethink our strategy of regular recruitment maneuver. And the reason why I think that recruitment maneuvers in the recent studies have not shown benefit is probably we are overdoing it. I've seen in the ICU, patients are being done recruitment maneuvers many times in a day by people who are not trained to do a recruitment maneuver, and hence I think in recent studies the evidence of benefit has not come. So compared to other strategies which are universal, like low tidal volume and like low keeping the plateau pressure less than 30. Recruitment maneuver is not a universal strategy. It should be done in all patients, but may be done in selected patients. The only recruitment strategy that is recommended in all patients which I think Dr. Paul will comment on, is going to be prone position. So prone positioning is the only strategy which, besides recruitment, has other advantages as well. Is one strategy which can be routinely recommended in patients with moderate to severe ARDS. But as far as recruitment is concerned, I think which patients are to be recruited should be decided by the highest level consultant, and should be done very, very carefully and not as a strategy in all patients. Dr. Indapal?
Yes, I totally agree with you, sir.
So I think we'll just summarize that, sir, for the audience, that it is not something which you have to do repeatedly once, and it should be done early in ARDS, and then the requisite precautions should be taken, and definitely it is not something which is going to save the patient. It is one of the things which is physiologically based, and understanding that we should do the recruitment maneuver, and definitely sometimes the lungs get de-recruited, patient get disconnected or some procedure, etc., then definitely recruitment maneuver has a role. So that is just to recap the entire discussion on recruitment maneuver. So I think with that, we will move on. Over to you, Dr. in the call 6 seconds.
So Dr. Tapesh, this open lung concept has became so
Okay,
controversial
so
that
patient.
yeah. Okay, Dr. Indapal, we can go on.
Yeah. So we did do a recruitment maneuver in this patient in the case that I was showing. So he had a recruitable lung, and thus a recruitment maneuver was done. But despite that, he continued to be hypoxic. So what are we really missing? So once you've done, you opened up the alveoli, you opened up the airways. What you really want to do is you want to prevent those opened up lung units to collapse again. So that is where comes the role of PEEP, which is giving positive and expiratory pressure. So you want to give an optimal end expiratory pressure so that the lung units which you have been able to open up do not collapse. So what happens during inspiration and expiration? So during normal tidal, if you ask me about a spontaneously breathing patient, when we breathe in, we have a negative airway pressure, negative thoracic pressure, which gets transmitted to the pleura. So the pleural pressure is negative in a normal spontaneously breathing patient, and the alveolar pressure, which is the pressure in the alveoli, is positive. So at the end of expiration, the pleural pressure will never exceed the alveolar pressure. So it is the transpulmonary pressure which actually decides whether the lung units will collapse or not. So when we intubate the patient, what we are doing? We are taking away the glottis. So let me give you an example. You take inspiration, you exhale as outwards as much as possible. You still not be able to collapse your lungs completely because the glottis will close. But by doing an airway intubation, you are taking away this physiological end expiratory PEEP. So that is why you need to give some physiological PEEP in all your ventilated patients, which is about 3 to 5 centimeters of water. Leaving that thing aside, what happens in ARDS is because the lung is damaged, so higher airway pressures get transmitted to the pleura, and the pleural pressures actually become more positive in some areas as compared to the alveolar pressure. And those pleural pressure, the difference between the airway pressure is transpulmonary pressure is the difference between the airway pressure and the pleural pressure. So the pleural pressures are high, they compress the alveoli, and that is what causes the collapse of the alveoli. So by giving extrinsic PEEP, you give the PEEP which is optimal, so much so that it just counteracts the high positive pleural pressure and keeps the collapsed alveoli opened up. Okay, so that is the physiology behind giving extrinsic PEEP in patients with ARDS. So every ARDS patient will need it. The goal is to maximize alveolar recruitment and prevent repeated cycles of opening and closing. So if the lungs keep on opening and closing like this, they close completely, open, close completely. So it causes a lot of stress and strain on the alveoli, and it causes a lot of inflammatory secretion, and this is what is called as biotrauma. But there is generally no consensus how to best set the PEEP. It has to be individualized. We are really worried about the shear stress due to cyclical opening and closing of the alveoli during tidal ventilation, and that is why we want to prevent that by giving an optimal PEEP. So there are many strategies that you can use to choose an optimal PEEP. One is to use the nomograms. So ARDSnet protocol has given us nomograms. Based on the requirement of FiO2, you can set PEEP. So they give a nomogram. So they have given two tables based on FiO2, how to set PEEP. So one is the low PEEP strategy and another one is the high PEEP strategy. I will show you in the next slide. The next way to do is to look at the respiratory mechanics and look at the compliance, driving pressure, pressure volume curve, stress index, and using the esophageal manometry. And recently, people have started using electrical impedance tomography, using bedside ultrasound. What ultrasound does is that at baseline you see the number of V lines, and by increasing the PEEP, you see where you get the minimum number of V lines and the alveoli open up. And the other one is thoracic CT, which is not always possible. So I will not be talking about imaging at all. I will be mainly focusing on gas exchange and respiratory mechanics. So like I said, the ARMA trial has given us a low PEEP strategy, and our alveoli trial has given us the high PEEP strategy. So if you look at this, the PEEP is exactly 2 times the FiO2 requirement. So 0.48, 0.510, 0.612, 0.714. So this is an easy way to remember. So for beginners, this is okay. Okay, just how much ever PEEP you are giving, FiO2 you are giving, just set 2 times the value of that FiO2 set, and you set the PEEP on that. On the other hand, the high PEEP strategy really involves giving a higher PEEP at lower FiO2. This is to avoid collapse of repeated collapse of opened up alveoli, and there's a rationale behind that. So in this meta-analysis involving patients with and without ARDS, they showed that if you use a high PEEP strategy in patients with ARDS, you will reduce the mortality. So if you have to use PEEP, you would generally tend to use a high PEEP approach. Then I had shown you the pressure volume curve in my previous slide. When we did a recruitment maneuver, we got a pressure volume curve. So what is pressure volume curve? So basically it is increasing the pressure gradually and seeing what happens to the delivered tidal volume. So at low tidal volume and at low pressures, most of the alveoli will be collapsed. And as you increase the pressure, these collapsed alveoli will start to open up, and you will see that there is a sudden deflection where you will see an exponential rise of pressure and tidal volume. So at low increase in pressure, you will see high increase in tidal volume, till you reach a point where even if you increase the pressure further, the volume will not increase. So this is the upper inflection point. This is the lower inflection point. So somewhere in between you have the ideal peak. Some say 2 centimeters above the lower inflection point. Some says 2 centimeters below the upper inflection point. In my mind, it would be anywhere in between. So in a different patient, it would be anywhere in between, and it is somewhere in between that you need to choose. So this is another slide just representing that as you increase the pressure, how the collapsed alveoli will open, and you will be able to achieve good ventilation in all those collapsed areas till you see a point where there is no benefit of further increasing the pressure. So this is the concept behind lower inflection point, where the shape of the curve changes and you see an exponential rise in the tidal volume compared to the pressure. So in this curve, as you see, here is the pressure volume curve, which we did on one of our patients, and gradually the volume is increasing, and at this point there is a sudden change and there is an exponential rise. So this is the point where I would say is the lower inflection point. As you see, this is highlighted here. It's a lower inflection point, and anywhere between here you would set the peak. Another way, if you don't have this tool with you,
just like to add that this pressure volume curve has to be constructed. It is not something you can just pick up from the ventilator, the PV curve that it shows. Each point has to be constructed, and it is a tedious process, and though it is one of the methods for setting PEEP, it is not useful clinically. Very few ventilators actually allow you to do this, and it is more of a theoretical concept, but the concept is very well valid, like explained by you. Please carry on, sir.
So, like Dr. Bansal said, not all ventilators have this PV tool and allow you to do this. It should not hinder you from doing whatever you have with you. So another way to see is looking at the stress index. So what you do in stress index is you ventilate the patient on volume controlled ventilation. Patient should be completely paralyzed. You should be using a square waveform. I/E ratio should be 1:2, and then you see what happens to the pressure curve. So if you see a concavity downwards, the patient has to be completely paralyzed, mind you. If you see a concavity downwards like this, it means that the stress index is less than 1, and you can increase the PEEP in your patient. If on increasing PEEP, you are able to achieve a straight line, it means that you have achieved an optimal PEEP. So this is a stress index of 1 and is an optimal PEEP. If, however, on the other hand, if you see that concavity is facing upwards, concavity upwards on pressure curve, it means that your stress index is more, your alveoli are getting lower distended, and you need to reduce the PEEP. So there you need to reduce the PEEP. This is another method. What another method we do is we ventilate the patient on same tidal volume. Patient is completely paralyzed, we gradually start to increase the PEEP. So I increase the PEEP by 1 and I see what happens to the lung compliance and what happens to the plateau pressure. Generally, on increasing the PEEP, the lung compliance will increase. Okay, all these things you can measure in your ventilator, and the plateau pressure will also increase by 1. So on increasing PEEP by 1, plateau pressure will increase by 1. On increasing PEEP by another 1, plateau pressure will increase on 1. So gradually you keep on increasing the PEEP. Then there will come a point when you increase the PEEP by 1, the plateau pressure will increase by 2 or 3. So it means now you have reached a point where you are over distending your alveoli by increasing the PEEP, and then you should set the PEEP about 1 to 2 centimeters below this point. Okay, so all you need to do is write down tidal volume, write down static lung compliance, write down plateau on a piece of paper, and on increasing PEEP 7, PEEP 8, PEEP 9, PEEP 10, keep on writing these things on a piece of paper, and you will be able to draw a graph and see that suddenly there will be a fall in the compliance and there will be an inappropriate increase in the plateau pressure. So this is another strategy that I have used in the ICU. Apart from that, some of the high-end ICUs would
Sir,
be
may I
using...
interrupt? Sir, may I interrupt? Not in the policy, sir. So just to add to that, sir, what is stress? Sir has very nicely explained stress index as a means of using your ventilatory strategies. But what is stress? So stress can be understood as the distending pressure in the lungs when you are inflating the lungs. During your tidal ventilation, the distending force in the lungs is the stress. And this is actually the transpulmonary pressure approximately. You know, when you inflate the lungs, there's a pressure in the lungs. And this pressure in the lungs is actually the negative of the transpulmonary pressure. You are putting a pressure on the lungs while you're inflating, so there's a force. Now the force coming back into the lungs is the stress. Action is equal to reaction, like the Newton's third law has been described. So that is the stress in the lungs. Carry on, sir.
So, like sir said, that the best way to measure the alveolar distending pressure is by measuring the transpulmonary pressure, which actually requires a special kind of an esophageal balloon, which basically measures the changes in the thoracic cavity in the esophagus, and we extrapolate that these changes would be roughly telling us what is happening in the pleural cavity. The best way is to put a manometer in the pleura and then measure the pressure, but that would require you to create a pneumothorax, and it is best avoided. So what we have in our hand till date, till the current technology, is the use of esophageal balloon, which basically measures the esophageal pressure that reflect the changes in the pleural pressure. So you can titrate the PEEP so that you are able to achieve a PTP peak. Mind you, I showed you in one of my previous slides. Just remember PEEP and PTP peak, which is the transpulmonary pressure at the end of expiration, and it should be more than 0. What does that mean? So I will again explain. So normally what happens is the pleural pressure is negative, and generally it is never above the intrapulmonary pressure. But what happens in ARDS especially and in positive airway pressure, that the pressures not only get transmitted to the alveoli, they also get transmitted to the pleura because it is a continuous flow. So in ARDS, especially if you have heterogeneous ARDS, higher pressures, especially in the pulmonary ARDS, higher pressure tends to get transmitted to the pleura. So pleural pressure becomes more positive as compared to the intrapulmonary pressure. So if pleural pressure is more, example, tension pneumothorax, what happens there? The pleural pressure is more than the entire lung. What it causes? It causes the entire lung to collapse. So similarly, if the pleural pressure is higher than the intrapulmonary pressure, it will collapse all the alveoli. And this is what we want to avoid. How do we avoid that? By titrating PEEP so that the transpulmonary pressure at the end of expiration is kept above zero. Okay, so this is a video which shows that. So the same goat lung model of ARDS, it is ventilating, and we are using the esophageal catheter in this patient. I told you that the pink reading is the esophageal pressure monitoring, that is the transpulmonary pressure, and this is the alveolar pressures. Okay, so what we want to do, you see that the pleural pressure, the pink pressure is higher than the alveolar pressures, and that is why the lung units tend to collapse. Okay, so we gradually increase the peak, and you see that the esophageal pressure is gradually becoming lower than the alveolar pressure, and see how well the lung has opened up and it is not collapsing completely. Okay, I hope it is giving you a good visual thing. So the lungs have not only opened up, but the optimal peak is avoiding the lung units to completely collapse, and that is why you saw that the lung volume has increased. So this is the lung volume at the beginning. So see the lung volume at the beginning, and once you set the lung optimal peak, look at the lung volume. So this is the exact role of optimal peak. Okay. So we've also published this, that if you use the esophageal pressure monitoring wisely, you will be able to better select a peak. In this case, we found that peak was 2 to 3 centimeters higher than what we were getting by using the lower inflection point, and it reduced the physiological dead space and the anatomical dead space. So you see that both the alveolar and the physiological dead space had reduced using the transpulmonary pressure, and the dead space to tidal volume ratio was also lower. So in selected group of patients, you will be able to properly titrate your peak using the esophageal pressure. However, in this large trial, we did not find any benefit of using the pulmonary, the esophageal pressure monitoring guided strategy compared to the conventional ARDSnet protocol. Why so? So again, in this study, a lot of patients were of moderate ARDS. Plus, I had also told you initially that some of the patients with extrapulmonary ARDS would benefit from setting up of a higher peak. So what we feel is that using this strategy would be best fitted for patients with extrapulmonary ARDS, as was highlighted in one of this case that we saw.
So,
This,
sir, just like to summarize, and what beautifully said. You have showed the EP went to study, and as you know, Gattinoni, who is the pioneer in ventilation in ARDS, he himself has published a paper, very recent and detailed paper on transpulmonary pressure, and quoted that the EP went to has gone contrary to their propagation of transpulmonary pressure as a guide to setting peak. Now, for all our audience, what is transpulmonary pressure? It is your plateau pressure or your driving pressure minus your pleural pressure. Okay, so that is your transpulmonary pressure. Now, the thing is, if your lung is less compliant, then your transmission of pressure from the alveoli or from the lungs to the pleura is going to be less, and your transpulmonary pressure is going to be high. Now, in conditions like that, sir said, things like obesity, things like pleural effusion, things like raised intra-abdominal hypertension, these constitute a very significant fraction of our population. Even patients develop chest wall edema, you give a lot of fluids. So these patients, the pleural pressure rises, right? And you are assuming a normal pleural pressure when you are using a plateau pressure of 30. In all these studies, in most of these studies where P flat has been kept as 30, you have not measured your pleural pressure. So in these conditions of obesity, of chest wall edema, of raised intra-abdominal pressures, your pleural pressure is going to be higher. Therefore, measuring fluid pressure is very important and very helpful here, because your plateau pressure here can exceed 30, and thereby giving you more freedom in ventilating these patients and allowing more successful outcomes. So I hope I was able to make that clear. So definitely, there's a very big role for measuring your pleural pressures, which is done by your esophageal catheter, because this allows you to set a proper plateau pressure, which exceeds 30 in cases of obesity and the other conditions I mentioned, because here your pleural pressure goes up. So that is very important. And as far as the numbers are concerned, now the problem here is it is very difficult to give a number to your transpulmonary pressure. Why can't you fix a number for transpulmonary pressure? Okay, because the lung is very heterogeneous, and the transpulmonary pressure is much more near the pleura, right? Because obviously the pressure is coming from the thoracic cavity. So the number approximately in the last paper that I read, maybe anybody else wants to comment, and I think Dr. INDERPAUL Singh sir has alluded, should be 0 to 5 at end of expiration. That is, your transpulmonary pressure should be 0 to 5 at end expiration, and at end expiration it should be less than 25. So if any numbers are to be given, if there are questions or for the students vivas, etc. So those are the numbers currently. So that is what I wanted to say about transpulmonary pressure, which is a very important factor in your ventilatory settings. But the problem is, to have your transpulmonary pressures, you have to have an esophageal catheter, which is a very cumbersome and not a user-friendly thing in the ICU. Thank you, sir. And the other thing is, even with your esophageal catheter, it does not give you the right pleural pressure. Thereby, it can lead to errors. So the device has to become more friendly and has to become more accurate. Thank you, sir. Over to you.
Yeah, Dr. Yeah, just one small addition. Yeah, as you have already said, Dr. INDERPAUL and Dr. TAPESH, you have already said that transpleural pressure is the pressure which determines the lung trauma or ventilator-induced lung injury, and your plateau pressure, which is the most important pressure while setting up the ventilator, because is the surrogate of transpulmonary pressure and which is the marker for ventilator-induced lung injury. So this is a surrogate pressure. This is an indirect pressure. So that, as Dr. TAPESH has already said, that is why because in certain cases where extra pulmonary ARDS is there you have the ability to go beyond this plateau pressure limit, because your plateau pressure limit is 30. So if your pleural pressure is already high because of chest wall edema or because of ascites or because of intra-abdominal hypertension or because of obesity, in those cases in general, if you're not able to ventilate and you can take the liberty of going little bit higher on the plateau pressure limit, which is 30, you can exceed it to 32, 33, 35 till 35, because you don't have esophageal catheter. Most of the ICUs, they don't monitor the esophageal pressure, which is also the marker of pleural pressure. So in case you don't have the esophageal pressure monitoring, that is why it is important to understand that in secondary ARDS, your plateau pressure limit sometimes can go high if you're not able to ventilate and you are not able to get the goals of your ventilation. Yeah, Dr. INDERPAUL.
Yeah, over to you, sir. Please go.
So what also happens is that it also optimizes the PEEP. So what I have seen is that in some patients who have severe ARDS, where we are trying to increase the PEEP. So on increasing the PEEP in some patients, actually the dead space ventilation increases. And if you do not use proper techniques to optimize your PEEP, by setting inappropriately high PEEP or low PEEP, you might actually increase the dead space ventilation. So there you might have a role in those patients who are difficult to ventilate. So if not all, I would suggest that you try to use it in patients, and in fact that is what we also do. We ventilate, use this strategy only they are difficult to ventilate and they have severe ARDS which is not responsive, and we are not sure what exactly is going to be the best PEEP for them. And yes, the transpulmonary plateau pressure should be less than 25. transpulmonary peak, that is end expiratory pressure, should be kept between 0 to 6. So this brings us to the next concept, which has been fairly recent, I would say, that the driving pressure. In fact, it is the pressure which is required to open up the collapsed alveoli. And if we know this pressure, what exactly the pressure is required, we might be able to achieve our target of achieving the optimal setting of both tidal volume and peak. So what exactly is driving pressure? Driving pressure is plateau pressure minus P. Okay. And what is static compliance? Static compliance is tidal volume upon plateau pressure minus P. So if we do some changes and if we write the equation again, driving pressure is directly proportional to the tidal volume and is inversely proportional to the static compliance, which means if your compliance is low, which is an indirect marker of severe lung injury, your driving pressures will be high. So high driving pressure suggests that the lung injury is severe. So ARDS is severe. Okay. So higher the driving pressure, worse the compliance, and severe is the lung damage. So we still don't know what is a good driving pressure. In one of the largest data that we have from the ARDSnet protocol, and this was published by Amato, if I remember correctly. There they suggested that if you target a driving pressure of less than 13, so those with a driving pressure of less than 13 had a better survival, had more benefit in the using this strategy as compared to higher driving pressures. So much so that driving pressure was found to be an independent predictor of survival, even adjusting with the tidal volume. So whether you use low tidal volume strategy, if your driving pressures are high, your patients are going to die. So they suggested that it is not the low tidal volume, but rather the driving pressure which decides whether the patient is going to live or whether the patient is going to die. So in nutshell, this strategy is still evolving, and I tried to look at the literature whether there are some papers on that. I could find 2 papers. This is one of the RCT which ventilated patients targeting a driving pressure of 10 or less. What they did was they set the peak and tidal volume accordingly, and then they gradually reduce the peak. And if you see, the peak in driving pressure strategy is lower as compared to the control group, and also if you see, the plateau pressures are significantly lower. So it is significantly lower than the magic value of 30. Okay, just see here. And on this, they showed that they had some survival benefit. The duration of ventilation could be reduced with this strategy. However, they have only included 30 patients. Okay, so the data is very less. I could also find another RCT which in fact showed benefit in mortality if you use driving pressure strategy and compared it with low tidal volume strategy. So I think this is a hot topic, and we will see more evidence coming in this strategy. And they showed that if you target a driving pressure less than 13 by adjusting your PEEP and tidal volume, you could actually improve survival. However, this paper again had small numbers, and it gave no information regarding the plateau pressures and other parameters, including the etiology of ARDS. So the jury is still out. It looks like a very good concept. Let's see how it turns out. So coming back to the case, so we set the PEEP to 17 based on our strategy. However, he still required an FiO2 of 0.8. So what next? So I think the only thing that we are left with is prone ventilation. So we prone the patient. The rationale behind proning is to see this 2 figures. So in a supine patient, you see the number of alveoli which are collapsed, and in a prone patient, you see the number of alveoli that have opened up, and there is more homogeneous distribution of ventilation. Okay, and if you apply the P, it gets equally distributed to all your patients. So it is the homogeneous distribution of the extrinsic PEEP also if you prone your patient.
May I just interrupt?
Yeah.
So about driving pressure, like sir said, it is still to be validated. Amato published this large statistical analysis using the trials earlier, which was published 6-7 years ago. Though physiologically it sounds more appealing, and the data did show better in survival using driving pressure. It has to be validated, like sir has very nicely showed two recent trials, small trials. But then again, we should remember in driving pressure, they have used plateau pressure. So it suffers the same drawback as the plateau pressure, that your pleural pressure and thereby your transpulmonary pressure is not being used. So that should be borne in mind. So those subset of patients, like discussed earlier, obesity, intra-abdominal hypertension, etc., will not be the same as the patient shown by Amato so far. That's what I wanted to add. Please carry on with proning, sir.
And what proning also does is that it takes away the weight of the heart, and it lets the dorsally situated lung units to open up. So you have a physiological rationale, but it took a very long time to get us evidence whether it will really help. So we had a very large Prosevad trial which actually demonstrated that prone positioning in severe ARDS is actually going to reduce the mortality. So after the ARMA trial, this is the one trial which has actually shown to reduce the mortality in patients with severe ARDS. What they did, they proned all patients with moderate ARDS as defined as P/F ratio of less than 150, and patients were included within 36 hours. So early in their disease they were included, and they gave proning session for about 16 hours in each day. So it was not a prone session for 4 hours, 6 hours as in previous trials. So they gave prolonged proning sessions, and they discontinued proning if there was improvement in oxygenation for at least 4 hours. And they showed that there was benefit in the survival and the reduction in the number of hospital days. So more than 15 meta-analyses have been done in the past, and proning has been shown to improve the survival in our patient. So we proned the patient and we started waiting. So now it is a routine in our ICU that we prone patients, all our patients who have severe ARDS. In fact, this proning has been extrapolated to COVID ARDS, and many patients have been asked to do self-proning even while breathing spontaneously. So proning actually improves oxygenation. Whether it improves survival in mild ARDS of COVID is again a question that needs to be answered. Okay, so proning is a very good strategy that we must all do. But again, for proning, you need to have certain checks. Patient should not be on a very high vasopressor requirement. Ensure that tube is properly placed. Ensure that your ICU is adequately staffed. Ensure that patient is adequately sedated. Otherwise, he is likely to move and take out the tube, and whatever good you have done might actually turn out to be harmful. Also, ensure that patients' face is turned frequently, because otherwise it will cause pressure sore on the face. Okay, so that is about proning. Should I proceed, or you want to add something?
You are finished with proning, sir?
Yes.
So I think proning we have covered. So we have had a separate webinar. So I think we'll let it go. So please carry on. Proning has been discussed in our previous webinar.
So once proning, the decision to prone the patient has been taken. Another question that comes to one's mind is whether we should be using neuromuscular blockade. So the theoretical rationale behind it is that it reduces the oxygen consumption by reducing the patient's work of breathing. It helps us to control the mechanical ventilation properly. It reduces the patient ventilator asynchrony and thus avoids repeated alveolar collapse and overdistension. However, it also increases the risk of neuromuscular weakness if used for a prolonged duration. And in this Accurate trial, the use of neuromuscular blockade in patients with P/F ratio of less than 150 in the initial 48 hours actually showed improvement in survival. However, in the subsequent Rose trial, the survival was not shown, and the current guidelines suggest that routine use of neuromuscular blockade should not be done. So why there was difference in the Rose trial? The difference was because it was stopped prematurely, number one. The intervention group had more cardiovascular events. Number three, a deeper level of sedation was used in the control arm as compared to the previous trial. So these are certain differences between the previous trial. Okay. So based on the current evidence, what we would recommend is that you should not be routinely using neuromuscular blocking agents in all your patients of ARDS. However, it may still be a consideration in patients who require prone ventilation, who have severe ventilator dysynchrony despite adequate sedation, and who have unwanted motor refractory movements that are not responding to your ventilatory strategy. So if patient has got severe dysynchrony and despite your change of ventilator settings, patient is not responding, then you might consider neuromuscular blockade. Finally, coming to the role of inhaled nitric oxide, it is a potent local vasodilator and it acts on pulmonary and not on systemic vessels, and thus might have some role in patients with severe ARDS. So the rationale behind is that the vasoconstriction is caused by hypoxia. I had told you that severe hypoxia will cause selective pulmonary vasoconstriction. However, in ARDS, you also have a lot of inflammation, which counteracts this hypoxic vasoconstriction, and thus you have increased ventilation perfusion mismatch, increased shunting. Okay, so what inhaled nitric oxide does is that it diverts the blood to better ventilated regions. So it in fact improves the ventilation perfusion mismatch theoretically. It really has not shown much benefit in patients, and should only be used as a rescue measure if you have not been able to oxygenate your patient despite all measures, and it should be used as a bridge till you have additional therapies that can become available to you. So this is a meta-analysis of many studies and has not shown to be benefit in patients with ARDS. So coming back to our patient, the patient gradually improved after proning, and we were able to reduce his FiO2 and finally wean him off and extubate. So to conclude, ARDS is a syndrome, mind you, and should be properly defined. The diagnosis should be proper after ruling out all other causes of acute hypoxic lung injury. It has acute onset. You should know the origin of edema. It should not be cardiogenic pulmonary edema. You should have distinct radiological findings, and you should categorize the severity of hypoxia. It is due to injury of alveolar capillary membrane, and it's a self-perpetuating cascade. Unless you take care of the underlying cause that really caused ARDS, you will not be able to save your patient. Mechanical ventilation is pivotal in management of ARDS, and you should use lung protective ventilation in all your patients. Use high feed, keeping the plateau pressure less than 30. Use early prone positioning in all your patients who have severe, moderately severe ARDS. Escalation of therapy should always be there in your mind if you are still not able to achieve your targets. Mind you, ventilators are only machine, and it is us, the clinicians, who will run the machine, and that is why the clinical skill is the most important. Thank you very much.
Thank you, sir, for your wonderful presentation. I think the video of the lungs is showing inflating and inflating really because to another world. And there were some lovely comments. Any questions there? Please kindly put this up. So, Dr. Arshad, are you there? Just to
Yeah.
So, would you like to say anything about why the Berlin definition we use a peak of 5? Because it is important to try and understand what is this concept of using a peak of 5 in the Berlin definition.
Actually, just prior to Berlin, there is no consensus.
1 minute, sir. Stop the screen sharing. Doctor, just close the screen, sir. Untitled Singh, sir.
Should I stop sharing?
Yes, stop the shares now. You finished, so please stop.
Yeah, prior to
So you have to
Berlin
stop the
definition,
1 minute. Just stop the share. Yeah. Okay. Thank you. So please,
yeah,
answer, sir.
prior
Please
to
continue.
prior to Berlin definition, there is no consensus regarding the definition of ARDS. Okay, some people after Berlin definition will come. They have given that when we give the PEEP, that's the normal physiological PEEP. Then at that PEEP only we can able to differentiate that whether it's a mild or moderate or the severe ARDS. Whether we are using PF ratio or SF ratio.
Yes, I think that is the thing is that one has to categorize the patients because different patients will have different kinds of ventilatory strategies. So, for the sake of classification and uniformity, this PEEP of 5 was used, and even on an NIV of 5, you can use its definition, and
Yeah.
thereby you will able
So
to.
you cannot use, technically, you cannot use this definition if you are using peak of 5 or even 10 with NIV, technically. So why this definition, why there was a consensus for that was because to homogenize inclusion of patients in clinical trials. So to improve that and to have a uniform definition, this was used. And this is specifically based on the data of patients who have been elective, who have been mechanically ventilated. And that is why a physiological PEEP has been used. If you are not intubating the patient, you still have your physiological PEEP, which is the glottis. So as I told,
So
so
I will.
technically speaking, uh, you should not be using this definition in non-invasive
I
ventilating patients.
will
But
agree
you're
with
right. That is the
you.
policy of this definition.
Sir, I will agree with you that the original trial was like that, but it is very well accepted that on NIV of 5 this ARDS you can more classify it.
So,
The second
so
thing is
many of my papers get rejected because of that.
there is no the other thing you have said, it is a physiological peep. Do you, Mishra sir, do you agree is there any physiological peep in the body, in the lungs? Dr. Mishra
Yeah,
sir.
I'll dwell on what you were saying.
I disagree. There is no physiological PEEP or the glottis because in the normal lungs, the end alveolar pressure is zero. This was an old concept.
So
There is end
physiological, I
alveolar
think the
pressure in the
word
lungs at the end of alveoli is zero, sir. There is no physiological PEEP. It is
so
not because of
physiological.
there is no
So,
the PEEP of 5 has not been used because there is a physiological PEEP. It has been to homogenize the population because different patients were on different settings, thereby classify them into these 3 categories. That is why I brought up this, why the PEEP of 5 has been used. It is very interesting. That is my view. If you agree or not agree.
see, I'll tell you what. Why the good thing that Berlin definition has done, I think, in my opinion, is two. Number one, Dr. INDERPAUL has already pointed out that it made inclusion into clinical trials more homogeneous, so that these trials were comparable, and we have seen the results of those in the last 5 years. There have been number of clinical trials to improved our knowledge. The second thing was to improve the clinician's understanding of ARDS. If you see the literature, almost 50% of the patient's ARDS diagnosis is missed, and it is still missed. So what Berlin definition has done is to make the diagnosis of ARDS simpler, to be able to be applied to a wider population. Does not need any sophisticated instruments. For example, in the previous definition, there was a use of PA catheter to exclude the cardiac cause of pulmonary edema. So what Berlin definition has done is that it has made diagnosis of ARDS easy and easy to understand for the clinicians. That is what I think as far as physiological PEEP is concerned. That I don't understand that concept. I don't think it is a loosely used term for patients who are given something like 3 or 4 millimeters of PEEP on ventilator without understanding whether the patient requires PEEP.
So actually, when the patient goes onto the ventilator, there is an atelectasis. To counter that atelectasis, we are giving the PEEP. So on the
Yes.
ventilator, you can use the term physiological PEEP. But in the normal lungs, there is no physiological PEEP simply because the end alveolar pressure at the end of expiration is zero. Anyway, so Dr. Arshad sir, you have any comments? You have been listening, and for the last 2 hours I have been silent. There's been a lot of discussion. Any other comments, sir, you want to make from your side?
So I will take up that question of transbronchial lung biopsy in ARDS. So transbronchial lung biopsy in any patient who is on an invasive mechanical ventilation should always be avoided because it can cause lung injury, it can cause pneumothorax, and it can cause persistent bronchopleural fistula. If at all we have any doubt, because most of the time you will have doubt between you require biopsy to diagnose acute interstitial pneumonia. So there, the practice at our center is we go in for the lung biopsy, the surgical lung biopsy or the VATS guided lung biopsy. That is what we do. We don't do bronchoscopic guided lung biopsy in this case. The diagnosis of atypical infections is mostly made by BAL, and it all depends. If the patient is already ventilated, you will be able to do a mini BAL using the suction catheter, or you will be able to do a bronchoscopic guided BAL in those. And most of the infections can be diagnosed by doing a bronchoalveolar lavage. Mind you, the bronchoalveolar lavage samples millions of alveoli compared to transbronchial lung biopsy, which just samples hundreds of alveoli. So you have a very small sample with transbronchial lung biopsy. So we generally do not perform lung biopsy, bronchoscopic guided lung biopsy in patients who are on a ventilator.
Sir, which patient should undergo
I think
lung
that's a
biopsy?
center to.
Either
I think that's a
transbronchial
center
or
to center.
which patient should undergo biopsy in ARDS? Lung biopsy. What is the policy that you will have experience?
So we only perform lung biopsy in patients where we have a clinical suspicion of acute interstitial pneumonia, and we are not able to rule out acute eosinophilic pneumonia, which one is responsive to steroid, another plus minus responsive to steroid. So these are the cases where we would generally go in for a biopsy. But over the years, we have seen that whether you do a lung biopsy or you don't do a lung biopsy, it really doesn't help in improving the patient outcomes. So we have published our data, especially in patients with acute exacerbation of underlying lung parenchymal disease, acute interstitial pneumonia. So we have published that paper, and at least to our understanding, making a diagnosis of AIP really does not make a difference. They have a very poor outcome.
Sir, that is your experience. Thank you for sharing your experience. But I think there is some difference in the literature, because one is that we have to manage the complications. Often they get pneumothorax. We may not be so good at that. But as far as the Western literature goes, in textbooks of pulmonary and critical care and in the papers, first is the pre-test probability. You have to make a clinical judgment whether this is typical ARDS or whether it is a ARDS mimicker. If you think that it is a ARDS mimicker, then doing a biopsy has made a difference because it makes a difference to the treatment strategy, right? So that is in the published literature, but of course every center has its own experience, and you have shared your experience, and I think you are the premier institute or center in the country could be having experience with ARDS.
So let me ask you this question.
I too.
What according to you are the ARDS mimickers that really require biopsy? You asked me this question, so I'm asking you. So you give me a scenario.
Sir, there are enough conditions. You have listed.
Give me one condition, then I will tell you.
Sir, you have listed eosinophilic pneumonia. Then
for eosinophilic pneumonia, I will do a bronchoalveolar lavage, demonstrate eosinophils more than 25%, and the diagnosis is made.
Sometimes they may not be sometimes there may not be enough eosinophils in BAL and eosinophilic pneumonia.
Then it is not acute eosinophilic pneumonia.
I too agree with.
There are many conditions. Let me come in. I agree with Dr. INDERPAUL. In Dr. Tapan, in the last 2 years, I have done transbronchial lung biopsy in only 2 patients. One of them was we suspected AIP, and the other one we suspected PJP. Although the clinical pattern was not typical of it, and we did find in both the cases made a diagnosis. That's how unfrequent And that is why I, rested the final comment from Dr. Inderpaul, because if he's working at a tertiary care center and if he's not doing it, but of course there may be center to center variation. There are number of very aggressive pulmonologists in Europe and Italy who may be doing transbronchial lung biopsies in ARDS. So I think it's a center to center thing. But I agree with Dr. Inderpaul. It's too much of a risk, and except some premier tertiary care centers, it's very difficult to do and convince the relative that there's a high chances of complication that may happen after.
Okay, fair enough. We'll end the discussion here.
Dr.
But I
Bansal,
think vaccine, if possible, can make a difference because the treatment strategy differs in certain conditions.
So in context, so just
actually,
I just want to make one. Yeah,
Dr. Bansal,
Dr. Tapesh, I just want to make one comment in context of this discussion. In context of this ongoing discussion of the need of the transbronchial biopsy or PETs in lungs in ARDS patients to diagnose ARDS mimickers. So even if the ARDS, no, the ARDS mimickers are able to give steroids. So what is the role of even ARDS? There is a of steroids. So Dr. Inderpaul, what is your opinion? I think we have missed this in management. What is the role of steroids in management of ARDS? Yes.
So I would say the steroid has a
when it should be.
So initial trials showed benefit.
Used in how much steroids and what are the trials which are against? And now, what is your strategy in your ICU use of steroids in ARDS? Also, if you could be COVID.
So the role of steroid in ARDS is very restrictive. We generally tend to use it in patients who have got persistent ARDS who are not improving. How we know not improving, we measure the lung injury score, and if it is not improving by more than 1, and the patient is within 7 to 14 days of his illness of ARDS, and we've ruled out all the infections, there we tend to give steroid for persistent ARDS. That is where we use steroids in persistent ARDS. But as a routine, we are not using steroids in all our patients of ARDS, which is contrary to the ARDS or the lung damage that you see in COVID-associated pneumonias, and also in some cases of community-acquired pneumonia, because there is evidence. Yes, please.
Okay. Yeah. Is that okay, Dr. Jyoti? So, Dr. Inderpaul Singh, one thing before I finally conclude, a lot of these patients go to fibrosis. A lot of these patients go.
There is no role of antifibrotics.
No role of antifibrosis.
Yeah, definitely.
But we still give.
Outcome of
Are you stop giving? I've seen PGI prescriptions with orphanidone. So are you giving or have you stopped?
What should you do with these patients? What should you do with these patients who go into fibrosis? What is their outcome? What should be the ventilatory strategy? Should they be abandoned, or what is your advice and outcome?
So if I am at a hospital in Europe or US, I will ask him. I will take him up for lung transplant, because that is the only option that he has. He has no other option. And if I feel that lung is the predominant organ that is involved, and there are chances that this fibrosis might resolve with time, then I might give them the option of taking these patients on ECMO. But again, with ECMO, if you have to take this patient, it has to be early in the disease, because you might have done damage till now, and that is why they've gone into the fibrotic stage. In general, a patient who is into fibrotic stage of ARDS is unlikely to benefit from anything else. So you can try to wean him off. Lung transplant is the only thing that is the option for him.
Isn't it? That is
no, Dr. Inderpaul. What is your take on using anti-fibrotic agents in the initial part of the COVID pneumonia? When they are very sick, they are on ventilator at the time of onset of the disease, and whenever you are treating the patient in the ICU itself.
So based on my current understanding of use of antifibrotics in DPLDs. So based on that, one thing is that they take time for their action to come. Then you would say, why not use nintedanib, because it might be used, it might show effect early. So that is all conjectural. We don't have evidence for that. One may choose to use, one may not choose to use, but it can also cause harm. So it can cause, especially if in COVID, you have a lot of prothrombotic stage. Patients are at high risk of MIs. And in those select group of patients, nintedanib can be more harmful in patients who have got an underlying cardiovascular disease. So there, that is a contraindication for that use, the use of nintedanib. Then the nintedanib can cause lung injury.
Dr. Nipul, your opinion?
So I have a comment on opinion. I have a comment and question to Dr. INDERPAUL. So a lot of these post-COVID patients who continue to be hypoxic after like 7 to 10 days are labeled as post-COVID interstitial lung disease. I feel, and I've seen in my practice, a lot of them don't have interstitial lung disease. They are slowly resolving pneumonias or organizing pneumonia. If you see the initial definitions of HRCT findings of COVID-19 was supposed to be an interstitial organizing kind of pneumonia, and I think that a lot of these patients basically have a slowly resolving organizing pneumonia, which improve over 2 to 3 months of time. Established interstitial lung disease would not be expected to improve, and I think that many of these patients, with or without pirfenidone, would actually improve on low doses of steroids. And I've seen that is why one of the reasons why most of this, almost 70-80% of the patients at the end of 2 or 3 months are off oxygen and doing quite well. What is your opinion on that?
So we have evidence for that.
And yes, do you have any historical studies on
we have just sent the RCT for publication. We have compared 10 milligrams of Vislon with 40 milligrams of Vislon in post-COVID lung disease, who continue to remain hypoxic, who continue to have lung changes on CT, and we have given them 6 weeks of 10 milligrams of Vislon compared with 40 milligrams of Vislon tapered over 6 weeks. What we found is that there is no difference. There is no difference in patients being on oxygen or their improvement in dyspnea score and other quality of life scores, whether you use low dose Vislon or high dose Vislon, which is 40 mg. This is number one. We also found that most of these patients recover, and only a few patients, so I would say 3 or 4 out of 100 patients would still have remnant changes on the CT imaging, and those patients we are now randomizing to use of antifibrotic agents. So after initial 6 weeks of steroids, if they have not shown any improvement, there we are now randomizing those patients to antifibrotic agents.
Okay, INDERPAUL sir.
There you could use antifibrotic agents.
We will take a break there. We are running short of time now. So the only thing is about fibrosis, the thing is if there is no transplant available and if there is no ECMO available, then often fibrosis dissolves. So over some period of time, it has been shown for reasons not clear, fibrosis does dissolve, and if ventilation is possible, we do the best ventilation strategies. Then there's a question, if at the end of expiration alveolar pressure is 0, then why is there residual volume? If pressure is 0, then alveoli should be collapsed. So I'll repeat it again. If Dr. Satish has asked, if at the end of expiration alveolar pressure is 0, then why is there residual volume? If pressure is 0, then alveoli should be collapsed. Anybody wants to answer that, or should I answer that?
So you answer. You are the ones who said that there is no physiological peak.
Because the pleural pressure is -5. Because the pleural pressure is -5, the transpulmonary pressure is 5, so it pulls it out. That's why there is residual volume at the alveolar end alveolar pressure of 0. So I hope that answers that. That is why the lung is kept open. Okay, so now I will just come to the conclusion. We are running, we are out to reach the time. One is we have forgotten to talk about when is high PEEP applicable and what is high PEEP. So Dr. Inderjeet had shown some slides, but it is not clear what values are really high PEEP and what are low PEEP. One, the ARDS network has a high PEEP and a low PEEP, but those are very difficult to apply. It goes up to 24 in high PEEP. Generally speaking, high PEEP has a better outcome in moderate and severe ARDS, and low PEEP should be used for mild ARDS. Anything above 15 becomes high PEEP as a consensus opinion by experts, but there is no fixed number. Also, please remember 30% of the patients have acute cor pulmonale. And once you start increasing the PEEP, your PA pressures go up, your RV pressures go up, and your perfusion will decrease. Your cardiac output decreases, and the ultimate aim of ventilation is to deliver oxygen, which is a product of not only your saturation, but also because of your cardiac output. So if you go very high on the PEEP, your RV output, thereby your cardiac output will decrease. Okay, so that is one thing. Then we come to stress and strain. I try to explain what is stress. I will try to cover strain. We did not cover strain because that does not come into PEEP strategies. So just looking at the lung architecture, the lung has a structure, a basic structure composed of collagen and elastin fibers. There are two systems running, one from the hilum, one from the periphery, which merge together. This consists of collagen and elastin fibers. And this has a specific property called specific elastance, which remains normal in ARDS. And attached to this is endothelium, epithelium, macrophages, etc. So the moment you start stretching, you inflate the lungs, supposing the lung is ARDS and there is some injury already, you put the patient on ventilator, you start increasing the volume, right? Once you start increasing the volume, the change in volume over your FRC is the strain, right? It is the change, the deformation that is occurring in the lungs or in the alveoli. That is the strain. So the volume which is above the functional residual capacity is the strain, and any strain greater than 2 is supposed to be extremely harmful to the lungs and the alveoli. So that is strain. Stress I've already told you. And I think the other thing is about fluids in ARDS. So fluids, we know we have to go very conservatively with fluids, and how much fluids to give and whether we should go for vasopressors. This has to be decided. There's a closed trial going on, but generally please restrict the fluids. Be very careful with your fluids. And I think that's about all. We shall now come to an end. It has been an extensive discussion. Thank Dr. INDERPAUL Singh. Very well described, and lovely videos, lovely slides, and lovely explanations, and lovely presentation. And thank you, sir. Thank you very much. I thank Vipul Mishra, sir. I thank Jyoti ma'am, and I thank Arshad, sir, for joining us. Their valuable inputs from medicine, from pulmonary, and from critical care. And hope to see you again sometime. And I think with that, I will close you. And I thank Elores for providing the digital platform for this webinar. And we are available on YouTube. We have had 46 webinars so far. All the recordings under Young India Intensivist are available for all the audience, the young students to see. And this happens every week, 5 to 7 p.m. Our webinar on critical care in India under the aegis of Young India Intensivist. So you are welcome to see those videos and join us again. Thank you, everybody. And please, Muzaffar, please. Thank you, Loris.
Thank you.
Thank you. Thank you so much.
Thank you.
Thank you.